Thank you very much. It's a pleasure to share with you all the experience of the MRSA initiative that we had at the VA from the beginning. It started around 2007 in our VA hospital. So first disclosures, I have nothing, no potential conflict or interest in relation to this presentation. I'm not going to discuss any off-label products or of any medications. And the objective of this presentation is to describe what is the bundle for MRSA prevention, which was implemented in our VA hospital, and it's in all VA hospitals now. And the other objective is to understand the importance of surveillance in preventing MRSA infections. So first, I want to probably you all know these definitions of what is MRSA. MRSA is the Methicillin-resistant Staphylococcus aureus, and this is a bad bacteria that is resistant to multiple antibiotics, and it causes serious diseases and is very difficult to treat. It can be transmitted by the hands of patients, healthcare workers, or by contact with inanimate objects contaminated with MRSA. It's found that it increases the length of stay in the hospital, it causes increased morbidity and mortality, and increases the cost like any other multi-drug resistant organisms. And this is the most common that we have in most of the facilities. So it's very important to differentiate what is colonization and what is infection. So just to let you know, the MRSA colonization means the presence of the bacteria on tissue without symptoms or clinical manifestations of a disease or infection. And usually when a patient is carrying or is colonized with MRSA, we call it a carrier of MRSA. And it doesn't mean that they're infected, but they can still transmit the bacteria to other persons or objects. And then MRSA infection is when the bacteria invades and multiplies in the tissue, and it shows signs and symptoms of infections like fever, increased white blood cell count. You can have lesions on your skins or different organs on your body. So the MRSA bundle started back in 2001. This started in VA at Pittsburgh, and they worked with the CDC. And the goal for this was to eliminate MRSA and prevent transmission of MRSA. So they create these MRSA bundles. These MRSA bundles were used in some beta-sized hospitals. There were like 7 to 10 hospitals. I think Lexington VA was one of them. And then after they tried those hospitals, they spread it to all the hospitals from VA, all acute care hospitals in the VA. And this started in about 2007. All the hospitals started in the ICU setting first, and then after probably 6 months, it was spread to all the wards and units. So it was localized first in the intensive care units, and then it was all over the hospital. So what is the MRSA bundle? The MRSA bundle is comprised of first, active surveillance and screening. Second, contact precautions. Third, hand hygiene. And then the fourth one is the culture change. For the active surveillance, we were doing the universal nasal surveillance for MRSA colonization detection. So this active surveillance was performed to identify carriers or patients that were infected. And this was to prevent transmission from person to person, or from person to healthcare workers and patients. The nasal swab was performed on every patient that was admitted to the hospital, when they were transferred to a different unit, or when they were discharged. And then to do an MRSA swab, we had to educate the patient first, give them some information for them to read, and then we had to obtain a consent from the patient before we do the swab. Initially, the MRSA swab was done by culture, so we had to wait like 2 days to get the results of the culture. But then later, it was switched to a PCR that we can get the results after 2 to 4 hours of that test. And this is the kit that we use for the MRSA nasal swab. You basically insert the 2 cotton tips inside the nose and then put it in the container and take it to the lab, and you should have the results quickly after that. So the second component of the bundle is the contact precautions. And what we did was any patient that had evidence of colonization or infection with MRSA was placed on isolation. So anybody has to wear gowns and gloves whenever they were going into the room, and then leave it inside the room and perform hand hygiene, or either with soap and water or alcohol gel. The third component of the bundle was the hand hygiene. As we know, hand hygiene is really bad between healthcare workers, but this is the single most important measure to prevent transmission of infection. Healthcare workers were expected to comply with our policies of hand hygiene. Patients and visitors were educated and engaged and tried to have hand hygiene education. And sometimes we have observers looking at healthcare workers if they were performing hand hygiene, and if they were not compliant, we were reporting it to their supervisors to show them what we needed to do. And then the last component of the MRSA bundle was the culture change. In the past, infection control was kind of like the police, and everybody was afraid of the infection control nurse. They will announce sometimes, or people will start hiding from the infection control nurses. So this culture change means that infection control was going to be the responsibility of everybody that works in the hospital: nurses, doctors, and all our medical staff. And the staff was actively engaged in working with the leadership, with the MRSA prevention coordinator, and other staff to implement all the changes for these policies. And the MRSA prevention coordinator was the main person playing the main role in these MRSA bundles. So these are some of the duties that the MRSA bundle, for the MRSA prevention coordinator had. So she was overseeing the implementation and compliance of all the components of the MRSA prevention initiative. She was collaborating with leadership on the implementation issues. She was talking to administration. She was talking to infectious diseases. Nurse managers also were involved. Laboratory also was a big component, the microbiology lab. She was collecting all this data on MRSA, and she was reporting this to nurse managers, to infectious diseases, infection control, and administration. And she was developing and evaluating the policies and procedures relating to this initiative. She was also engaged on educating the frontline people on all the nurse stations. We developed kind of like a super users, nurses that they were trained, and they will train the rest of the nurses in the units. And then they were supporting the frontline workers in educating not only nurses and other healthcare workers, but families and visitors for patients. So this is the information that was published in the Courier Journal earlier. And you can see we started the MRSA initiative at the end of 2007, so we don't have that information here. And we start collecting the data from 2008 until now. And this is the colonization rate, so these are people that are not necessarily infected but has the MRSA, they're carriers. And at the beginning of 2008, our rate was 4.84, and then by 2013, our rate is less than 50%, it's 2.31. And this is probably the more important one, is the MRSA infection rates. And as you can see, when we started in 2008, our rate was 1.89 per 1,000 beds of daycare. And last year, in 2013, we had 0.09. So this was a decrease of about 95% on the rate of infections for MRSA. During this, you don't have this slide, but this was a publication that we did on the Journal of Kentucky Medical Association. Normally the publication is about outbreaks of infections, but we did a report of an outbreak of colonization. So these persons were not infected, but they were getting colonized in our hospital. And this was in the intensive care unit, so this is where all the MRSA initiative started. And the main findings that we have was that there were a lot of patients that were getting colonized with MRSA, and this was from a single route that the patients were being admitted. So we think that there was a inappropriate cleaning of the room, and the patient was coming into the room and probably acquiring MRSA. We did some DNA analysis of the MRSA isolates, and we were able to find that 4 of the patients have a common type of MRSA. So we kind of pointed that, but we couldn't prove it completely for sure. So our conclusion was that prevention of colonization should be one of the primary goals in preventing MRSA infections. So now I'm going to show you how is MRSA, how do we do surveillance. And these are the reports that we see almost monthly in our infection control meeting. So here, this is showing the admission swabbing of patients that are coming to the hospital. We're supposed to swab everybody in the hospital, but there's patients that refuse, and there's some patients that we missed. And our goal is to be above 90%. This is the VA goal, to get 90% of the patients at least swabbed on admission. I couldn't show the data, but this is how the graphic is shown. And you can see we have the number of patients eligible to swab, and then on the denominator is the number of patients that were admitted. And then whenever we have a problem, we assess, and then we make a plan of what's happening. Of course, we get the nurse manager of the unit involved if there's any problems in a specific unit, or if there's a specific nurse that is having problems. The second graphic is showing the MRSA swabs on patients that are discharged in our facility. And as you can see, the discharge was a little lower than the admission swabs. And we were a little below the goal a couple of months here. But it's showing also the same, kind of the same information as the previous one. And then the third graphic is a composite evaluation of admission and discharge swabbing. And the goal of this is also to be above 90%. Then here we're showing the colonizations of MRSA that we have over the last year until August of this year. And this is a rate per patient days of care per 1,000. And the colonization rate is more difficult to control. As you can see, I was very excited in March when we got no colonizations in the whole month, but then it went up again a little bit. So, and then whenever we have a colonization, the MRSA preventionist, she analyzes all the cases that become positive while they were in the hospital, and we try to figure out why the patient came negative and now he's going home or being discharged and got a positive swab. So we try to analyze how this patient acquired or got colonized with MRSA while they were in our facility. This is the one that is the important one, that is the infections. So MRSA infections, as you can see, we have just one infection in January, and we haven't had any infections since January until now. This has decreased significantly since before we started the implementation of the MRSA bundles. So in conclusions, the MRSA bundles decreased the MRSA colonizations and the MRSA infection rates in our VA hospital in Louisville, Kentucky between 2008 and 2013. And the MRSA bundles is a continuous process. You have to keep doing the screening all the time. There's always new residents, new nurses that you have to educate and train. And there's always things that changes, like I think recently the last change that we had was the observation. When the patient is admitted, it's in observation, and it was only 23 hours, and now it's changed to 72 hours. So our policy has to change because we're not doing swabs on the observations, just the admissions. So this is constantly changing, and we have to keep updated and educate all the healthcare workers about this. Okay, so this is my last slide. So thank you. Should I take questions?
Yeah, any questions? A lot of questions.
Yeah.
Sure.
Do you screen previously colonized patients or previously infected? So a previously known MRSA positive patient, would you rescreen them?
Our policy says that within a year, if you've been colonized within a year, you don't repeat, or infected or colonized within a year, you don't repeat a nasal swab. So you just admit it and put them in contact precautions.
Okay. And the other question is, have I read that you extended this program into the long-term care setting for the VA as well?
We don't have a long-term care, but Lexington has a VA nursing home, and they're doing it in nursing homes. And I think it also showed that there was a decreased rate of colonizations, infections with MRSA. And actually, one of the studies showed that it doesn't only decrease MRSA, but also other resistant organisms like BRE and maybe C. diff. But it's a very good tool now.
It's a great example.
Yes?
Will you describe your hand sanitation process, please?
Yeah. So the hand hygiene process is we have to use either alcohol gel or wash our hands with soap and water before we get into the room, before we put the gloves and gowns on a patient that is in isolation. And then when we finish the patient, we take our gowns and gloves and we perform again hand hygiene again. So it's before and after. And it could be either alcohol gel or foam, and also it could be hand soap and water.
Do you do any kind of surveillance on the hand washing compliance?
We are trying to improve that because the problem is that we have the only one that is doing this, looking at people washing their hands is our infection control nurse. And if they see her around, everybody's washing their hands. And also the other barrier that we have is that some of the healthcare workers take their gowns and gloves inside the room, and then they wash inside the room, or they use the alcohol inside the room, and we're not able to see that unless you're watching through the window what they're doing inside the room. So we tried to do the camera thing, but there was a lot of problem with putting cameras in patients' rooms. Okay, thank you very much.